So I'm going to speak a bit about Uber therapy and digitalization. So I'm taking an industrial relations and a sociological position on something that actually is very personal. In the past, I have worked as a psychotherapist in the NHS as part of my training. But actually my primary relationship with therapy is as a patient. And I think it's really hard to strike a balance between saying something important and critical and not making everybody feel really crap about what they do. So I want to start this event really with not with a disclaimer, but with a promise that being critical of IAPT or the IAPT model is not a criticism of the people working within it. This isn't an individual problem about us not working hard enough or not doing our work well. There is a systemic problem that we really need to understand if we're going to prepare for the future, because the future is emerging rapidly. And in my experience, even those of us working in the industrial relations field are not aware of how quickly we're moving from an Uberization, so a downgrading of a very important service, life-saving service, to digitalization, and what that might mean both for clients, patients, however you describe yourselves, we describe ourselves, and clinicians. I just want to also start by saying that I'm exhausted. And I'm raw after 6 months of no childcare with a 2-year-old child as a single parent, and also trying to maintain, I think, a career, but at least a job. And I know that this is the case also for people engaging in therapy. And I think it is, I'm just very grateful to the participants of this event for continually putting themselves forward to say important things. I've known some of you for a really long time, and we have been repeating ourselves for maybe a decade about what's happening. And I know that often we get to a point of frustration, particularly on social media, where middle-aged women don't fare so well. And we've all taken a sustained beating. I think that our bravery, our continued bravery and activism is crucial at this time, because talking about mental health puts you in direct opposition to the very powerful financial interests that are now at play. And I come from a trades union background. I used to work for the Miners International, so I have a sort of slightly paranoid and sometimes it feels like an exaggerated view of what can happen, how bad it can be in work, but actually my experience says it's worse than you think it possibly can be. And I think that if we are going to understand and even organise in response to what's happening, we have to be very serious about the amount of pushback there is for taking an alternative position. Gamification of the evidence base, I mean, gosh, hasn't that got resonance now? We're doing the track and testing, you know, it really is the worst kept secret in mental health. The IAPT model, and I'm talking about the IAPT model rather than IAPT services per se for 2 reasons. One is that IAPT services are very patchy. So there are some services that you could define as good, where people are working and they feel that they are able to work in a way that is therapeutic. Some services not. Also, you don't have to be working within IAPT in order to be using an IAPT model, because the financial model, it's not a clinical model, the financial model of IAPT is everywhere. It's the context within which public health services operate. And what has become really known is the gamification of the evidence, particularly around 50 claims of 50% recovery rates, and these very light CBT techniques. Most people would argue that they don't really constitute therapy in many cases, particularly online. So it's terribly hard just to say that. It is rejected. You are demeaned and humiliated if you raise this in any of the mental health settings. The professional bodies can't talk about it. there aren't very many spaces where you can have an adult conversation about why are we continuing with a system that is actually making false claims about what it's doing. And the question really, as a trades union question, is, so who is benefiting from this system continuing? So I want to present firstly just a little bit of data from all the many really bad surveys that I've done in mental health from the perspective of workers, people who work in the sector. It's all up on the futureoftherapy.org, another kind of stupid thing to do when you're academic, just give away your data, but there you go. And I just want to give you a different version of what it means to be a psychotherapist or counsellor or mental health worker in this country. So I did a big survey in 2017, 1,500 mental health workers. 28% of those workers outside of the NHS earned less than £300 a week. So one of the big secrets is that many people working in mental health are poor. Many go to food banks. And for those of us that have had therapy, the thought that our therapist doesn't earn enough money to eat is pretty challenging in terms of how safe we all are working in this way. 21% of psychotherapists and counsellors work unwaged, at least for some of their time, as part of their training, as part of their accreditation to professional bodies, but also people who've retired or who simply can't get paid work. So there's a chronic exploitation of a really demanding and highly qualified workforce to work for free. The pressure is there. I think it's almost impossible not to do that. I used to run a series of seminars when I was trying to organise psychotherapists and counsellors called "Do you have to marry a rich man to be a psychotherapist in the UK?" And the answer is, for many people, yes. 30% are self-employed, so there's also this sort of idea that people working in the NHS actually work for the NHS. Well, they don't. So, you know, many therapists have maybe 3 or 4 patients, so they're on 0-hour contracts essentially. 58% of IAPT workers raised concerns about patient care, and that's across the sector, it's 38%. So neither of those statistics should make you happy, but there's a significantly higher number of people within IAPT who are unhappy with the standard of care. I did another survey last year just for IAPT workers, and it's a relief that this statistic was finally kind of, you know, concretized. 41% of people working within IAPT have been asked to manipulate performance data. And that can be things like recovery rates, it can be in terms of people turning up, it can be redoing assessments to get a more positive response. 68% of IAPT workers have experienced depression and anxiety as a result of working within IAPT, and 70% have experienced burnout. And the question was quite uncharacteristically for me a very clear and well-defined question. It said, as a result of working in IAPT. Now these are catastrophically high figures. 68% depressed and anxious. These are the therapists. these aren't the clients. 69%, however, felt that they were providing good care. So there's a tension within the system of people who are struggling on, who feel that they're able to offer good care, but actually at a very, very high cost to them, both financially and also emotionally. I did another survey for a network called Partners for Counselling and Psychotherapy, which is a progressive network, which I think Claire might talk about later on, about the impact of COVID. And I think I'm going to redo that survey because 6 months on into this change, this radical shift in mental health work, because most of it has gone online. But what we found was that already 50% of self-employed mental health workers are not able to sustain themselves on their current income, and that was taken maybe 4 months ago, and 78% are not able to sustain themselves working for an employee assistance programme, which is one of the big sort of employers and growing employers in the sector. So the picture is already not good in terms of precarity and income insecurity. Now, Sandra, can you do me the favour of putting up my first slide, which is entitled Hurtling Down the Rabbit Hole? So I was feeling a bit kind of depressed about doing this talk because I think you have to be very careful about criticising actual commercial providers. You do have to be careful about it. But I've been to a series of online events like yourselves, which have just been so sort of audacious, where people have so freely spoken about what's happening within the mental health sector, particularly around digitalisation, that I'm going to give you some quotes from high-profile people who are working in the digital mental health field to give you a sense of how freely this is talked about. You don't need to be an academic to find out who is making money out of digitalisation of mental health services or what this means strategically. So this first quote is about the financial logic, and I think it is important. I mean, you could say this about academia and also mental health. It's important just to understand that the financial logic really does dominate. It's true what we write about neoliberalism. It determines what services exist. So this is from a private digital provider saying data insights improve quality while driving down unnecessary costs. So this is a company that is way ahead on using AI and automation to carry out monitoring, supervision, chat sessions, which are considered therapy by this company, and also diagnosis increasingly. And it's there to reduce costs. Another quote is from a company which designs apps and chatbots, and it says, "We are balancing user wants." And I'm just really fascinated by this terminology around user wants, that there is a commercialization that's happening and a commodification of the therapeutic relationship in this process. It's necessarily so. Another is from an online provider of therapy who is also engaged in data mining. So using the data from online sessions of their clients, 250,000 online sessions, to do data mining. So we're data mining therapy chats for cognitive and emotional tags in order to develop monitoring and diagnosis tools. For those of us who are labour academics, the whole thing around algorithmic management and surveillance at work, particularly around emotional and cognitive tags, is terrifying and, you know, a big area of research now. But I think one of the things that I take from this is it's important to understand that the technology does what it does. It doesn't necessarily do what we want it to do. So I don't think there's anybody working in mental health who thinks that more monitoring and more automated diagnosis, the medical model, is helpful in any way, or even comes anywhere close to providing therapy. Another point, so there's one person who's had a number of these quotes, said at the end, when I challenged him and I said politely, you know, have you ever heard of the National Audit Office of 2018 inquiry into the gaming of IAPT data? He claimed that he had never heard that the data that they're using, the IAPT questionnaires, standardized questionnaires, were giving false data. And he said, our data is published in journals. So I'm not going to have a pop at academia, but yeah, this stuff gets published as well. And then the final quote comes from one of the father figures of IAPT at a conference, at an IAPT conference at the end of last year that a friend of mine went to. And of course, the IAPT model is moving almost entirely over to virtual and digital services. And they asked the brilliant question, did anybody actually ask for this? And the father said, nobody asked for it, but we're still doing it. So that decision was made several years ago, and what's happened within the sector is COVID-19, which has speeded it up dramatically. Sandra, could you go on to the next slide? I will send out after this event a series of slides. So I just want to very quickly say this is not new, the idea of Uber therapy. By the way, when I started using the word Uber therapy, I didn't know that Uber Health actually exists as a commercial company. So in a way, I think it's quite useful to say, use this language, because there's often a confusion within mental health and clinical services that somehow we haven't been industrialized, that we're not talking about industrial relations when we really are. But the central argument that I think is right, and it certainly seems to be my experience, it seems to be backed up in my research and the interviews that I've done, is that the downgrading of therapy into a standardized, manualized, and now digital model has opened up the doors for the ending of clinical work, highly experienced clinical work in the public sector, and also the development of the emergence of big healthcare and digital providers, and the incredibly valuable industry of AI and data science, so the data wars. And mental health has now opened up to that. Next slide, please. So there are two things that I just want to say about that. We've talked for a very long time about what the consequences are for the therapeutic relationship. But again, I've used a provocative term, therapeutic Tinder. So what does happen to the therapeutic relationship when, for example, you access therapy through an online platform like Uber? It's only one form of employment, but it will be a growing one as people are sort of interacting remotely. And these are two quotes from two big online therapy providers. Therapy for all, wherever you are, whenever you are. Learn to live without the suffering that comes from depending on your partner, friends, or other people with the help of a specialist. Well, as far as I seem to remember, that is the agony of therapy, that you become dependent on somebody and you allow yourself to do that. And there is just something on a very practical level terrifying, I think, for a lot of therapists, that suddenly the image that they give, that their marketing ability, their commodification has to be done in order to attract clients increasingly. And then the final slide is really about algorithmic control. Again, it's another massive area, certainly for WES, is about how when automation is introduced, there is also an issue of algorithmic management, how both the client and the therapist are being managed. And there are really very important sectoral developments that are happening now to get the metrics to do this algorithmic management. So we already have standardized questionnaires or metrics for service users in terms of their recovery and the impact of the therapy. But there are also developments by these private digital providers to set up standardized metrics for therapists. And this is very closely linked to the big debate within the professional bodies around scoped, which is around regulation, but also introducing a capabilities approach to therapy. And these things are interconnected. So putting it bluntly, we are entering into a period of automation, of surveillance, and algorithmic management. Okay, Sandra, you can take the slides away. I just want to say something very quickly about how do we prepare for this. Well, I think carefully is my answer to that. I think one thing that I think we have to promise each other, certainly those of us that are involved in progressive networks, activist groups, is to understand and take seriously the issue of surveillance and try and protect the spaces where we meet and talk as best we can, given that we are going to be doing a lot of our organising work online. So I think getting up to speed, I'm personally heading off grid as soon as I can, but I think that there has to be a much greater knowledge and skill sharing and technological sharing between activist groups on how do we create safe spaces. But I think there is also an opportunity in the real erosion of trust in the evidence in our society to try and steer the mental health debates, which are chillingly positive and chillingly individualized and cynical as a result. that we have to be brave and we have to face up to the real lack of evidence around the current delivery of public mental health systems and find alternative ones. And I know that Debbie will speak to that. I think that there's a very painful statistic, and this is my final point, there's a very painful statistic in one of the surveys that I did, which is about how do people raise concerns with colleagues. So across the whole mental health sector, if you worked in the NHS, 14% would raise a problem with a colleague. But in the private sector and third sector, which is big, only 4% of people working in mental health are able to raise their concerns with their colleagues. So in a way, it sounds a bit lame, but I think there's something really striking about how important relationality is to people working in mental health as a discipline. This is what we do, we build relationships, and how little of our time has been spent in building relationships with each other. I think the technology is a really important part of that, and in the follow-up to this event, we'll be listing a number of progressive organisations and networks that you might consider joining. But I think that the primary concern is for us to conserve our energy so that we can do good work in pushing back the Uberization of therapy. And to do that requires real organising and us committing the time.